I had the privilege of working with Dame Cicely for nearly 20 years. It was often exhilarating and sometimes extremely challenging. So I'm delighted to be talking today about Dame Cicely Saunders and the hospice vision, and to ask the question whether hospice is fit for the 21st century. So the things I want to consider: what are the core values and legacy of the hospice concept? How does the vision stand today, and is it relevant to the future? What's the evidence for hospice efficacy in meeting need? And what role might it play in meeting future challenges? When Dame Cicely opened St Christopher's as the first purpose-built modern hospice in 1967, she started a revolution in the practice of medicine and the care of the dying. It's interesting to reflect that home care was established only 2 years later in 1969. From the beginning, Cicely understood that hospices were never going to look after all of the dying. She believed in care. She established the concept of total pain, but also in research and education to understand what we were seeing and to spread the message widely. The concept caught on, and in the UK now we have over 220 inpatient hospices, 360 home care teams, more than 300 hospital support teams. Palliative care exists in over 120 countries, but we should remember that's only half the countries in the world. And a recent study estimated that globally, only 1 in 10 people who need palliative care get it. Important to remember too that Dame Cicely believed that it was care of the family and friends as well as the patient, and care into bereavement as well as during the illness. What was her vision? Her early vision, a statement from 1958, and as I typed these words in, it just reminded me what a fabulous writer Cicely was. A team who work together to relieve where they cannot heal, to keep the patient's own struggle within his compass, and to bring hope and consolation to the end. That very realistic recognition that we can't take the struggle away, that there will be a struggle. The prospectus, as St Christopher's opened in 1967, the hospice will try to fill the gap that exists in both research and teaching concerning the care of patients dying of cancer and those needing skilled relief in other long-term illnesses and their relatives. So right from the beginning, that focused not just on cancer, but on other illnesses. And then in 78, the wider vision. There's a need for diversity in this field. A few hospices will be needed for intractable problems, research and teaching, but most patients will continue to die in hospitals or their own homes, and the staff they find there should be learning how to meet their needs. So always a philosophy, a concept, not a recipe, and an understanding that good end-of-life care needed to be available in all settings. Interesting to remind ourselves that care homes aren't mentioned there. And of course, over the last 20 years, we've seen a huge expansion in care homes. There are now far more beds in the care home sector than there are in the NHS. And those care homes are looking after people who are much more complex and frailer. Robert Twycross said memorably, movements tend to become monuments. And in a sense, the objectives for end-of-life care have been clear for some time. Everyone in every setting, everywhere in the world. All diseases, not just cancer. In England, 500,000 deaths a year, and about 170, it's estimated, receive specialist palliative care. 3/4 of those 500,000 are expected deaths, and just under half of those from cancer, yet only 10 to 15% of hospice patients have non-malignant disease. So there is a challenge present in Cicely's initial vision that hospices are not yet meeting. Good care has to be both effective and cost-effective. And we've known for decades what it's dependent on. the availability of opioid drugs, early identification, service integration, 24/7 services, good communication, support for patient carers and family, culturally appropriate care, adequate funding, the drive to the community, effective widespread programs of education, and evidence. And evidence is where we fall down. So thinking about care, research, and then education. Where are hospices on care? Who isn't being seen? John Hinton published his seminal text, Dying, in the same year that St Christopher's opened. We emerge, he said, deserving of little credit, we who are capable of ignoring the conditions that make muted people suffer. The dissatisfied dead cannot noise abroad the negligence they have experienced. And those muted people are suffering still. The WHO defined palliative care as impeccable assessment and treatment of pain and other problems. But most people don't get an assessment, let alone an impeccable one. In 2010, the Economist Intelligence Unit ranked the UK top for quality of death, which was followed, ironically, almost immediately by a raft of highly critical reports and documentaries detailing some quite appalling deficits in care delivery and continued exclusion. And it was clear from the reports that followed that this was often about attitude as well as resource. When you get hospice care, people seem to like it. It seems to be a good thing. Hospices in the Voices survey are rated significantly higher for quality of care across all measures. 77% rate it excellent. But it's important to recognise that 13% still rate hospice pain relief as inadequate. And Joan Tino last year wrote a very interesting editorial about the growing concerns of whether all hospice care in the US was really providing a good and consistent quality of care. Palliative care, much of it delivered by hospices, is associated with survival and improved outcomes for patients and families, with reduced hospital costs and reduced admissions and the increased likelihood of home death. So hospice can make a difference. But we know that access to hospice care is neither sufficient nor equal. And overall, in the UK, health inequalities are growing. The Marmot Review looked at the social gradient in health and proved rather conclusively that the wealthier you are, the healthier you are. We've seen cuts in health budgets and swinging cuts in social care budgets, added to which changes in state benefits mean that the poor are poorer. And I think hospices have been strangely muted on social justice. We know that few die how and where they wish. The postcode lottery in care persists, despite a small but welcome rise in deaths in usual place of residence that I think sees one of the good outcomes of the National End-of-Life Care Strategy. We know that there are significant spending variations for specialist palliative care, but that data inadequacies mean that we can't link spend to outcomes. We particularly know that access to hospice care and palliative care services in general is very poor for people from black and minority ethnic communities and for the deprived. And then there follows a whole litany of people for whom access to hospice and palliative care is poor. People with learning disabilities, the homeless, prisoners, travellers, the list goes on and on. And it isn't that there aren't some wonderful small initiatives going on. It is that there hasn't been a coherent, concerted plan about how we improve access. Hospice planning from the beginning has been random. It's been established according to local enthusiasms and willingness. And the unclear messaging from hospices has created public confusion about who hospice care is for and how you can access it. And of course, the public, many of the public, still believe that hospice care is inpatient care, rather than the fact that now the majority of it being delivered in people's own homes. There is ageism in all our services, not just hospices. We know that we're confronting an ageing population and increasing frailty with multiple chronic conditions and complexity in a context of social change, resource constraints and system upheaval. We're going to be meeting huge unmet need and a massive increase in demand. It's been estimated that the number of the oldest old with personal care needs will rise by 60% in the next 20 years. Remember those cuts in social care. And already 40% of the oldest old live alone. We know that preferences for hospice death increase with age, yet the oldest old are underrepresented. If a queue is a sign of failure, we have to ask whether hospices are complacent, over-engineered and overpriced, because they have a large queue. Not just the people waiting on a referral list, but the people who never get any access at all. Are we guilty of the inertia of the way we do things? Hospices have always delivered excellent care to the individuals who make their way to their doors, but they have a professional responsibility to think about populations as well as individuals. I said that ageism exists in all services. I was particularly taken by this comment in a Guardian leader at the end of last year. Caring for frail elderly people is now the core business of most hospitals. Imagine a commercial enterprise that regarded its principal customers as an awkward inconvenience. A home death is not necessarily a good death. Not all hospital admissions are inappropriate, and not all hospital experiences are poor. Perhaps it's time that we thought differently about hospital beds. Recently, St Christopher's closed its inpatient unit to undertake a full refurbishment. And while we did so, we opened a sort of hospice on a ward in Lewisham Hospital, and Lewisham Hospital were fantastically generous to us. It was a typical hospital ward. It didn't have any single rooms. There were no spaces to see people privately. The outcomes for patients were almost identical to those on the hospice inpatient unit, although the outcomes from bereaved relatives showed poorer scores for things like privacy and the ability to have good, clear communication with medical staff. Nonetheless, those almost identical patient outcomes made me wonder, is there a future in which some of the empty wards in hospitals will become places for hospice-supported wards and occupy a role in rotational training, so that there's some hospice staff but also nurses and doctors rotating through from the rest of the acute unit? Could we envisage a future in which some hospice inpatient units are better and more cost-effectively established as nurse-led units supported by GPs? We certainly found for some of the patients on Linden Ward that being in an acute setting made some of the treatments they needed much easier to obtain. I came to a very challenging seminar here in 2013 where Diane Mayer spoke. It was memorable. She made a critique of the concepts and language of hospice and end of life and wondered whether they were getting in the way of people receiving the palliative care that might help them earlier in their illness trajectory, because people were frightened by death and dying, by the words hospice and end of life. I think her critique is more relevant in a culture that has the bizarre incentives of an insurance-based healthcare system. I think it would be a disaster in the UK if we stopped talking about end-of-life care and hospice, because Cicely was right when she said that death needed to be brought back as a normal part of living. And we have made some strides which we mustn't lose in creating a more open culture around death, dying and bereavement. There really is more around in the public discourse and to everyone's benefit. I've been in hospice care for 28 years, and truly it has changed enormously. We also know that expressing preferences means that you're more likely to get what you want. And Gold Standards Framework and the Gold Standards Register and the electronic palliative care coordination systems give us evidence that that is so. We know that bereavement is a trigger for psychological and social frailty, and one study estimated that unmet bereavement need costs NHS Scotland 20 million a year. But we still have a very crude understanding of people's preferences and trade-offs. Place of death has reigned over supreme because it's easy to measure. And we know that as people get iller, their preferences change, and also they have other priorities, perhaps where they will get most support, or where they will get better symptom control, or not being a burden on their relatives. I'd suggest that it's not the concept of hospice and end-of-life care that's at fault, but the implementation and our behaviours, both professional and public. We've spent too much time arguing about the difference between specialists and generalists. The reality is that most services will do some of both. What we need is an effective joint response to need. So there is a case for change in hospice. Changes in demand and need, increasing and unmet public expectations, a more competitive environment, constrained and uncertain funding. Last year, 50% of UK hospices reported their NHS funding cut or frozen. And remember that that NHS funding on average for a hospice is only a third of its income. So a huge amount of public support pouring in to a National Health Service objective. There's an increasing need for proactive rather than reactive care as we work with an increasingly frail population. Our hospice is going to play a role in the much needed integration of health and social care, and hospices must do more for less. External stakeholders have rather mixed perceptions of hospice. They want to know where hospices sit in the wider system and whether they work to the same rules of transparency. Interestingly, when we merged with another hospice a number of years ago, we were able to save 20% of the cost base in 6 months and improve the service by adding a 24/7 home care visiting service. That can't be right in terms of cost base. And too many hospices reign too content with occupancy levels in the late 60s and early 70s, and children's hospices are even more guilty of this. External stakeholders want to know what principles hospices use over resource allocation and how they make decisions between quantity of people helped and quality. I would suggest to you that many hospices never even address that question. They're sometimes seen as poor partners, insufficiently self-critical and unaware of the wider system in which they need to operate. But what about the NHS? Professor Sir Bruce Keogh in January this year said, "We are not fit for the future. An unprecedented shift of resources and care to GP surgeries is necessary." And interestingly, much later on, he said, "The sickest patients need much more time to discuss their health." How true, how true. And how will hospices best work with and support GPs who will be doing most of the end-of-life care? Are we going to see hospice clinics in GP practices? Are we going to see hospice nurses co-located with GPs? How will it be? At the end of 2013, a generously Hospice UK funded commission, which was independent, into the future of hospice care, published its report with messages for all providers and stakeholders. It emphasised the importance of system-wide approaches, and particularly for hospices, the need to be adaptable and flexible. And I commend to you the evidence-based report about current and future needs for hospice care, which was produced by colleagues from CSI. It really does say it all. With the independence of hospices comes responsibility. And for me, over a number of years, I have seen 4 main responsibilities. Delivering good enough, please notice the good enough, cost-effective, evaluated care and service innovation that's easily accessible to those most in need and replicable at scale. Supporting the development of a confident and competent health and social care workforce. Spearheading efforts to change public attitudes and enable community participation. and doing the difficult and holding fast to the disadvantaged. Hospices are charities. And I think that issue of holding fast to the disadvantaged and doing the difficult should be in our DNA. It's no use saying we can't admit over the 24-hour period. And it's no use saying we can't manage people with primary and serious mental health difficulties because we haven't created good relationships with liaison psychiatry. My little phrase for where we should be aiming is living until you die and access to good enough care in whatever bed you die in, because most of us may not quite get what we choose, particularly if we look 20 years ahead. If hospices have a commitment to the mission that everyone should get the care they deserve, that brings an obligation to think about how best to use hospice resources as part of the system of care. That's an issue for all boards. I think hospice boards have got in the way of progress sometimes, but I'm pleased to say that increasingly hospice boards are asking themselves these questions. And joint needs assessments are leading to uncomfortable local questions for hospices. What care should be provided directly? What should be done to support the work of others? What should be done through education and advocacy? Should some services be withdrawn or reconfigured? Where can hospices work with others to do things better? Thinking about research now. Where are hospices on research and what isn't known? Well, the legacy first. You will all be aware of Dame Cicely's meticulous case studies of patient experience and pain, followed up as St Christopher's opened by Twycross and Walsh, working on pain control, morphine and more, and then Colin Murray Parkes on bereavement prognosis and outcomes, Hinton on depression, Carter and Baines on obstruction and dysphagia. Work continuing into the 90s with perhaps some of the very important early and meticulous research on home care outcomes for patients and families done by John Hinton. More studies in the 2000s. But I think by then at St Christopher's we were realising that hospices, even a large hospice, will never have the infrastructure at all levels necessary to undertake really significant research. So by 2008, we were undertaking studies jointly with the Maudsley on CBT and the largest ever study of depression in the UK, in the palliative care population in the UK, and then a randomised controlled trial on support in care homes. And I think this is true for all hospices, the requirement to create good research partnerships. But overall, the hospice response on developing the evidence base has been poor. And of course, there are wonderful outliers. I think there's been some great research coming out of St Joseph's, for example. But by and large, hospices have failed to allocate resources to evaluation, even though it's been clear for some time that it's no longer sufficient to be a good thing. Marie Curie has been another flag bearer for the importance of research. And I've sometimes felt over the last 10 or 15 years that perhaps hospital support teams have done more to carry the flame for research than hospices themselves. It's a matter of shame that we can say that roughly 80% of specialist beds exist in the voluntary sector, but we can't really say what quantum and what sort of home care is being delivered because hospice data is simply too inadequate to do it. It's vital that we achieve common data sets to share activity, costs and outcomes nationally and across the voluntary and the statutory sector. And I feel really cheered up by the work of Clark and Oak and the possibility of us cracking this one finally. It matters if we're going to achieve improvements in services and convince the broader NHS of the need for more funding. And every time I listen or read David Currow and the work that's going on in Australia, I feel uncomfortable about the clarity with which he has shown us the benefits of benchmarking. We need to know what support is most effective for whom at what cost. A review recently said that the need for home care can be demonstrated, but not how best to deliver it. That's dreadful when we've been delivering it since 1969. Most studies don't even differentiate hospice-supported home care from other kinds of home care. And yet the variety of hospice home care models mean that they would offer the perfect test bed. And I personally am also very interested in the notion of the effective dose to empower patients and families. Not just the effective dose of medicine, but the effective dose of support, because hospices have tended to throw everything at the individuals that they meet. I'm pleased to report that better research partnerships are emerging. Lots of hospices beginning to confederate and make really robust relationships with universities. But we need a determined focus on researching the gaps, not the things that we happen anecdotally to be interested in. We need to know much more about service configuration. We need to know more about bereavement. We need to know more about effective support for carers, and I could go on. And hospices in particular need to think about the impact on the research agenda of their ageing and part-time workforce. The responsibility to innovate should rest with hospices because they have, as charities and as independents, a very short idea to action time. They don't have to cope with the multiple layers of bureaucracy that exist in the statutory sector. And I just want to mention a few things that have been happening at St Christopher's that give some examples of how we can do more for less. Triaging home care, for example, so that only the first visit is a home visit and then patients and families who are physically able to get to the hospice to an outpatient clinic do so. That has released 30% of resources, and using our patient-reported outcome measures, we are getting the same outcomes as we did when we made those very expensive and time-consuming in London because of travel home visits. Unbundling daycare has meant that the facilities that saw 20 people a day using the facilities have increased to 200, a service run from 8 in the morning till 9 at night, 7 days a week because of the engagement of volunteers. Using our building as a community hub, running schools programmes, a choir, curry and quiz nights, death chat meetings, concerts, Sunday lunch and more, has given opportunities to engage with the community in a very positive way. And we've been sweating our physical resource by running a rehabilitation programme and a transition initiative at weekends. Physiotherapy in circuit groups led to a threefold increase in numbers supported, while at the same time bringing evidenced benefits to the individuals. And that is the wonderful space for some now 200 people moving through it a day. Hospices across the country are working hard at supporting the care that others deliver and supporting care in the wider community. There are many examples of bereavement services, both for children and for adults, that are open to anyone in the local community. And specialist lymphedema services would not exist in the way that they do if it weren't for the support of hospices. Hospices across the country have been working on supporting care homes. St Francis Hospice, for example, in Berkhamsted has got a really interesting training programme for care homes. And our own care home project, which has seen us training hundreds of care homes with Gold Standards framework, has led to a 25% increase in deaths in the care home. Sustainability initiatives, the sharing of creative artists, and triage telephone advice run through the inpatient unit. The Namaste Dementia programme for care homes, initiated in this country by St Christopher's, has led to a reduction in behavioural symptoms for those with dementia, along with massively improved satisfaction for staff and families, and generally improved quality of life for the residents. And that's now being rolled out nationally with a toolkit. Many hospices are experimenting with hospice-supported beds in care homes. Many hospices are experimenting with care coordination services. A great example, the Marie Curie delivering choice at Greenwich and Bexley Community Hospice. And our own experiment in Bromley has seen 20% home death rate rising to 83% home death rate, with only 8% of those supported being transferred to specialist palliative care. Hospices are looking at rapid hospital discharge services, and these are making a difference to those issues that were only again in the news today with NHS Scotland about the bed blocking that happens when people can't get out of hospital. Hospices also beginning large-scale delivery of personal social care and taking much more care over recruitment, training, supervision and support than any of the commercial agencies do. St Giles Hospice in Lichfield was a trailblazer in this field. Our own service gets wonderful feedback from those receiving it. One lady said of the person who visited to support her with her social and personal care needs, "He's such a well-mannered boy, and that is healing in itself." What society, what have we come to when it's a matter of exception to comment on somebody being well-mannered and kind? That service is seeing 70% home deaths. And almost more importantly, given the crisis that we've got in personal social care and the poor quality of much that is delivered, but also the exploitation of the staff who deliver it, to see one of our personal social carers saying, "I can't believe the way I feel at the end of a shift, even the stressful ones." She came to us from an agency. "When I get home, even though I feel exhausted, I'm also glowing with contentment and pride. I've never experienced anything like this before." How are hospices doing on education and training? The issue of developing a flexible workforce fit for future purpose. Interesting to remember that the St Christopher's purpose-built education centre opened in 1973. The legacy from that, lots of specialist training, an international focus, a unique multi-professional week established in the 80s and still running, a focus on motor neuron disease, on pain, on bereaved children and families, CBT, social care, gold standards framework, delivered by those who do the job. And that makes a difference in training. And then there's the MSc, run by King's in collaboration with St Christopher's. And I received an invitation to an event when I got back from holiday, and I was amazed to see that we had 300 students over the 15 years that it's been running, and that over half of them had written articles or published chapters. That really is about creating the next generation of leaders. But by and large, hospice training initiatives, and again, there are outstanding outliers. We might mention St Joseph's, we might mention St Oswald's, we would certainly mention Sobel House in Oxford and the Advanced Pain and Symptom Control course. But on the whole, hospice initiatives in training and education have been fragmented, duplicated, and lacking in scale and accreditation. Have we made a specialism out of a generalism? I've asked the question about the role of GPs, but how are we going to make the links that we need with geriatricians, cardiologists, respiratory physicians, psychiatrists and rehabilitation? Is it possible that there will be subspecialisms in end of life in those areas? A flexible workforce, it often seems to me far from it. Do producer interests dominate? And what's the role of professional bodies? It sometimes seems like protecting vested interests. We need to use training to drive change that is needed for future care. There's an urgent question to be answered about what skills specialist doctors will require in the future. What about dementia, pain management beyond cancer? And what about the community, in which very few of the young specialist doctors in training seem to be interested? How are we going to get nurses to support the development of health literacy? And how will we train staff to work across settings where they're most needed? We'll never deliver 24/7 services properly unless we do it together across settings. And how will we help people and services to be co-located? Hospices have to play a strategic role in training and education. And again, they must ring-fence human resource and money for this. We need to campaign for greater inclusion of end-of-life care on the undergraduate syllabus of all professions. And hospices need to devote some of their resource, and many of them do, to the vital task of young student doctors and nurses actually seeing good care in practice. We've lost the apprenticeship system that helped people to gain confidence by watching people who were confident in what they were doing and saying. I think hospices are now recognising the huge opportunities to develop the basic health and social care workforce, to develop a nationally endorsed curriculum for vocational education courses, and to work together to create consortia large enough to compete and win the funding needed. And there is now, for example, a South London education partnership, and Hospice UK has developed a national education consortium. We need to develop and share common products and the quality end-of-life care for all, in which hospices team up with supporting developments in nursing in acute and community settings, thanks to funding from Hospice UK, has been spread out nationally. So significant progress on the hospice role in training and education, but more to come. Hospices can give a great deal to the other sectors with their experience in using volunteers creatively. And for the future need that we're facing, they are key to resourcing change. We know, for example, that volunteers reduce hospice costs by an estimated 23%. And good training drives diversity. When we started offering a serious training programme at St Christopher's, our volunteer profile changed. We now have 37% under the age of 48, 40% men, and 28% of volunteers from black and minority ethnic communities. Hospices should be leading in the development of standard accredited portable training so that people can move between social care, NHS settings and voluntary sector settings with a base training that's accepted everywhere and then added to. We need to extend the kind of roles that volunteers can undertake, supporting the community, working with people with dementia, doing a bit of housework, the rota of handymen who can put up the grab rail that will mean that somebody can be discharged from hospital, volunteers to support research activity. We wouldn't have undertaken our care home RCT without the support of volunteers helping us with data management and collection. And volunteers to provide continuity of care when professional services are dipping in and out. We've got to challenge the barriers from within on the effective use of volunteers. It's usually staff who object to them. And we need to think about volunteer mentoring and volunteer management support roles. Hospices can strengthen community connections, involving communities in service development and the support and delivery of care. And there have been some interesting experiments by St Nicholas Hospice and Milford Hospice in Ireland. Education and training can bring two needs together. We've found at St Christopher's that volunteering can be an escalator for unemployed young people and returners to work. And some of our volunteers have subsequently taken up paid roles, for example, in our social care service. And along with St Giles, we've been running summer schools for young school leavers who might be interested in a career in health and social care. It's very important that we avoid getting out of step with the public. The Liverpool Care Pathway debacle showed us that very clearly. We need a clear shared narrative. I think the public understand rationing. What they want is clarity and reliability. They want to know what can be delivered and they want to know that it will be delivered. We've got to strengthen strategic leadership in hospices and manage the inevitable perils of individual organisational marketing to develop a collective voice. Drop some of our competitive instincts and get clarity and appropriate uniformity about access and services. I want to emphasise again that responsibility to reach out and respond to inequalities and to maintain support to the vulnerable and the underprivileged, which hospices have not always put into action. There is worrying US evidence of cherry picking by for-profit hospices. All organisations in end-of-life care need to think about how to value and develop all staff and volunteers. People need to feel that they belong and they need to feel noticed. especially important for middle managers. I think we need shared action learning sets, cross-sector mentoring and job exchange. I long had a dream, which never quite came off, of some of the consultant physicians at St Christopher's swapping with some of the consultant physicians in hospital support teams. I think if we could do more of that, and in nursing as well, we would really understand one another and come up with better responses to need. It's also important that we get transparency about risk. We've spent a decade now managing it. We need to learn to take it as well, especially if we're going to give good creative services to frail older people. We need to support our staff in having discussions with families and the public about risk. Support them when the risk that we've identified comes true, but also help families to decide on what's an acceptable level of risk, because risk there will be. So, what is my feeling about whether hospice is fit for the 21st century and whether it really matters still or whether it should just be allowed to wither on the vine? I believe that we can transform care, end-of-life care, and meet the challenges of the future if we do it together. Hospices cannot do it alone. We can create a health and social care system fit for the 21st century, and we must. I'm going to need it. But hospice care remains vital in that vision. Hospices are rooted in communities, and that brings unique resources. They're repositories of professional, compassionate confidence and competence, and people can catch confidence when they're in confident environments. They have multi-professional teams accustomed to working together to support complexity. They offer the breadth and depth of services that future needs demand and the freedom to innovate. But hospices mustn't wait for a fair and level playing field, for an invitation, for the respect they think they deserve. Morale and culture in some parts of the NHS is a real threat to the continued development of end-of-life care. And tick boxes, and let us remember that they have a habit of multiplying, because you keep thinking of another thing that you ought to do and another thing and another thing, and then they overwhelm everyone. Tick boxes are not a substitute for thoughtful care. Hospices should act with urgency, responsibility and generosity, but they must deliver evidence. In addition to partnering well, hospices should remain restless, disruptive, and a little bit sceptical. We need to know sometimes when to stop doing something instead of carrying on tinkering with something that's basically wrong, trying to make it a bit righter. We need to remember that care is not a commodity, particularly in end-of-life care. A professional prescription written out against known and identified problems is something we create together, professionals, volunteers, communities, patients and families. We can't put a chocolate box around the experience of dying, wrap it up and put a ribbon on it, but we can make sure that people aren't left on their own. So to end, Cicely's vision from the 50s remains as relevant today as it was when she first penned it. A team, and of course now we should be expanding that concept of team across all sectors. A team who work together to relieve where they cannot heal, to keep the patient's own struggle within his compass, and to bring hope and consolation to everyone to the end. Thank you very much.